So I think that Vali is supposed to say what an idiot I am and say it's the future's is combination. So we'll get to that. But I think that there is and always will be a place for single agent therapy. We have a landscape now where we have 3 drugs in lung cancer approved in the pre-treated patient population. We have nivolumab, which was the first approval in all comers based on survival advantage over docetaxel chemotherapy. We have pembrolizumab, which was initially received accelerated approval for the subset of patients who had more than 50% PD-L1 expression, and more recently approval in the more than 1% group as well based on KEYNOTE-10. And then it presented at ESMO just recently and published in The Lancet was the atezolizumab OAK trial, which also showed a survival advantage in the second and third line space, actually, with atezolizumab with a very favorable hazard ratio. So I think we can safely say that second line therapy is immunotherapy as single agent is the standard of care. We now have data in the first line setting with pembrolizumab in the PD-L1 positives as well. So I think today, my argument is that these agents are effective, particularly with PD-L1 selection. So I think going forward, we will continue to use PD-L1 selection for lung cancer, and hopefully we'll have better biomarkers so we can define those patients more precisely. Combination immunotherapy, combination with chemotherapy and immunotherapy and other combinations are clearly of interest. But when you give combinations in general, they do have more toxicities. And until we see some phase 3 data, I'm not convinced that the combinations are here to stay. And so we know the patients that will respond to these therapies, and they typically, do have PD-L1 expression. PD-L1 is a co-stimulatory molecule which opposes the effector signaling of T cells, and tumors can upregulate PD-L1 as a mechanism of immune evasion. I think this is a patient that responded to PD-1 therapy, and then the immunohistochemical chemistry slides here, I think beautifully depict the immune evasion, where you have high levels of PD-L1 at the tumor margin, and you have on the top panel T cells, which are to some extent within the tumor, but at the tumor margin are heavily infiltrated. So your T cells are there. They basically are just not functional. So if you have this sort of perfect storm of T cells that are there and PD-L1 highly expressed, then these patients will respond to immunotherapy. One of the challenges has been defining what the optimal cutoff is to these therapies, and we've been kind of working on this for a long time. But I think that we can safely say that there is a threshold effect where we see a clear enhancement of responsiveness based on the KEYNOTE-110 and now KEYNOTE-24 data, that the high positives, which are 50 to 100%, tend to respond best to immunotherapy. And I think that I agree that for the low positives and the negatives, we definitely need to develop combination strategies. But for the high positives, it's likely that single agent therapy is the way to go. When you look at the PD-L1 expression in many trials, including Checkmate 057, which was a non-squamous trial randomizing nivolumab to docetaxel, clearly all comers, the hazard ratio was favorable at 0.75. But as you go up on the PD-L1 expression from 0% up to more than 10%, you see a clear improvement in overall survival at 2 years from 25 to 45%. So KEYNOTE-24 was in New England Journal and presented at ESMO. And this was the first line trial that I think has really changed how we practice oncology in the last couple of weeks. It was a frontline trial with no EGFR or ALK patients, and good performance status were enrolled. The patients were randomized to pembrolizumab versus chemotherapy. And in this trial, it was for high positive patients with a tumor proportion score of more than 50%, which is about 30% of non-small cell lung cancer patients that we see up front. And clearly the benefit is seen here with the complete response rate of nearly 10%, overall response rate of 45% versus 28%. So I think that this, along with the survival, the time to progression-free survival benefit, it led to this drug being approved frontline. So I think that the standard of care now is to do EGFR ALK and your mutational analysis, but I think part of that needs to be PD-L1 testing. I would argue that these drugs do work better in the frontline setting than post-chemotherapy. You have data showing a 10% complete response rate with pembrolizumab in this trial. If you look at the KEYNOTE-10 trial, which was pembrolizumab in the pretreated population, there was no complete responses. We're now seeing data with pembrolizumab and atezolizumab in bladder cancer showing a higher response rate frontline versus pretreated. So I think there are advantages to giving these drugs first line. I think one could argue, well, I'll give them chemo first line, and then if they doesn't work, then I give them PD-1 second line. I think there is a reason to select these patients who are going to have these high levels of response and deep responses for the frontline setting. So I think that single agent seems to be particularly helpful earlier on. The progression-free survival is here. So those patients, those in the audience that chose 4 months as the PFS advantage, that's the correct answer. 10.3 months versus 6 months. Corey answered it wrong, no, I'm just kidding. This was a very clear survival advantage. The overall survival was similarly superior. At the same meeting, what I had the misfortune of discussing was the Keynote 26 trial, and it was really a very similar study design. The main difference was the threshold of positivity in that trial was for the PFS benefit was 5%, which is with a prevalence rate of about 50%. And so it was not as select a patient population. I think this difference does speak to the need for a higher threshold of selection. But as one looks at the trials, it was really hard to understand the differences between these two trials. I would not conclude in any way that pembrolizumab is a better drug than nivolumab. I think that every data set in terms of second line and phase 2 data would suggest comparable response rates. I don't think the biomarkers are different. You look at the prevalence rate and response by level of expression, they seem to be the same. I basically don't have an answer for the difference in outcome. There may be more precise methods of identifying patients for immunotherapy, so benefiting from single agent therapy, and that could include looking at tumor mutation load or neoantigen load, and it probably is not going to be enough on its own. When we looked at mutation loads, sure, it predicted to some extent, and if we look at above the median versus below the median for the cohort of the patients that we did whole exome sequencing on in patients that were treated with pembrolizumab and lung cancer, the median was about 200. So when we looked at anyone with mutations above 200, and any level of PD-L1 expression, so it could be 1% or 5%, we're able to identify those patients for durable benefit with a high level of sensitivity and specificity. So I think it's going to be a composite score that one looks at as we go forward in terms of identifying patients for single agent therapy. These drugs are more toxic when you give them in combination. I think that if you look at the melanoma experience, those patients that were PD-L1 positive did not seem to benefit from the combination of immunotherapy versus single agent immunotherapy, whereas the negative patients did. And so I think that as we look for PD-L1 positive lung cancer, there still is going to be a role for single agent therapy. If you look at the toxicities, though, of course, there are more with Nivo and Ipi in combination. And then when you look at kind of the updated longer-term data, there's a high level of adverse events with the Nivo and Ipi combination. More than half of the patients had grade 3 to 4 toxicities, although this was at a higher dose of a CTLA-4 antibody. And the toxicities that we see are really challenging, and they can include skin, GI, endocrine, hepatic, pulmonary, and renal. One of the other challenges with combination immunotherapy and with immunotherapy in general is that the toxicities are a little bit unpredictable. You can see kind of the error bars showing a wide range of time to onset of these toxicities. So skin toxicity do tend to occur early, GI, endocrine, hepatic, pulmonary, and renal as you go along. But you can see these toxicities span, a period of, close to half a year. And so one has to be constantly vigilant to monitor for toxicities, as they can really occur at any point in time. In the lung cancer experience, the combination did show some encouraging efficacy data. However, the treatment-related AEs were 3 to 4 AEs were 37%, 33 to 37% with the combination of Nivo with IPI, even with a low dose of IPI. And this compares is more than with the Nivo alone, which was 19%. I think that if you look at the discontinuation rates, they were relatively comparable. However, managing these toxicities in patients' quality of life, I think, are relevant when one thinks about single agent versus combination immunotherapy. And this just speaks to the scope and extent of toxicities we see with the Nivo and IPI combinations in the left two columns versus Nivo single agent on the right. Similarly, the Durva and Tremi combination, which is also in clinical development, had high rate of grade 3 to 4 related AEs at nearly 30%. One of the issues with both of these trials is that they're relatively short in terms of follow-up. And so as we use these drugs and administer them for more extended periods of time, we do see more toxicity. So if you simply look at Keynote 24 versus Checkmate 26, where the exposure was longer in Keynote 24 because the higher PD-L1 selection, patients were on treatment longer, you can see the grade 3 to 4 AEs rates clearly going up to 26% versus 17.6%. So as we embark on immunotherapy combinations, I think that one will see a similar effect where as we continue to dose these patients, we're going to see more challenging toxicities in the combination arena. So to sum up, I think that single-agent immunotherapy is the standard of care in the second-line setting. We have 3 drugs to choose from: atezolizumab, pembrolizumab, and nivolumab. In the frontline setting, PD-1 therapy is the standard of care for patients who are PD-L1 positive with a 50% threshold with a 22C3 assay by Merck, with the prevalence rate of about 30%. One of the unknowns as we use this clinically is that the assay has been done off of typically surgical samples or core biopsies, and how do we apply this clinically to our patients if we have only an FNA or an EBA sample? We don't have a core. Do we need to rebiopsy these patients? And I think the short answer is probably yes. What do we do with patients who were not included in the clinical trials that we conducted, such as patients with autoimmune disease? Should we treat those patients? And I think the answer is maybe. I had a patient recently who had MS, and she was, it wasn't just quiet MS, it was real MS. And so her PD-L1 score was actually 30%. So she got first-line chemotherapy. And now what do we do in the second-line setting? Clearly, her response rate with 30% expression is going to be far superior to second-line chemotherapy. Is it worth the risks of exacerbating her MS? Be curious to know what the audience thinks, but we are actually going to go ahead and treat her. It's been a bit of a mixed bag in terms of worsening of autoimmune. In my experience, some things get worse, some things don't. So it's really a matter of weighing the pros and cons. And I think the PD-L1 score does help you. I think if it was 0, I probably would have elected to give her docetaxel as a second line of therapy. So that's all I have about first-line therapies. Vali's going to convince you that the combination is where to go, and we'll leave it to Vali. Thank you for listening.